repolarization, which is the T wave. Right? Repolarization of Purkinje fibers, that is what leads to sometimes that U wave. Right? Sometimes when the U wave is present. Okay. ECG leads, we divide it into two parts: limb leads, chest leads. Limb leads bipolar, they are 1, 2, 3, and that is what leads to formation of Einthoven's triangle. Unipolar, they are the augmented leads. That means one particular lead which is used, the rest of the leads, they are turned zero, right? So that you can actually get the clear difference. So we'll be using the right arm, left arm, and the left foot. Correct? Left foot. And unipolar, they are V1, V2, V3, V4, V5, and V6. So this is what we talked about multitasking. This was Einthoven's triangle. This is Cabera system, where we have superimposed everything, which you now know pretty well. Important thing to see is that left lateral side of the heart, that is seen by best lead 1, but also by AVL. The right side is seen by AVR, and from the inferior aspect, it is the AVF. From V1, V2, V3, V4, V5, V6, all the way, right, the long axis, that is parallel, so to V3, V4, V5. So these three will be important when we'll be discussing about the left ventricle. Anterior part, that is seen by V1, V2, even V3 also, right? But anterior part. But V1 and V2, they are typically for the AV septum, right? AV septum, V1 and V2. So a complete Cabera system, also called as the hexaaxial reference system. This is one another important part, but no need to cram, because now you know everything. This is like from 1, you close your eyes and you will find that yes, this is the lateral part. 2 and 3, yes, they are the inferior part, right? So no troubles. AVR, obviously it is on the right side. AVL, so that is on the lateral side, because AVL was over here, 1 was over here, so they are on the lateral side. AVF, yes, AVF, this is the foot side, correct? V1, V2, that is the septal, we just talked about it. V3, V4, they are the anterior. V5, V6, they are the lateral, right? So done. So that is how we really got it. Then we got into the business of calculating heart rate. Right? Before that, we said that this is first thing, QT interval. QT interval, that should not be more than half of the RR interval, right? And that is what we calculated over here. As the electric axis is towards the lead 2, so that's why there will be tall QRS complex, correct? Tall QRS complex, and that is what we see it over here, right? See the QRS complex, that is pretty tall as compared to lead 1 or lead 3. So that is second point. Third point is V3, V4, V5, because they are facing again the axis which is directly in front of heart. So that's why they will also be having tall QRS complex, and then you can see that V3, V4, and V5, they are having pretty tall QRS complex. Right? Just this, so you can see that. And finally, the easiest one, AVR. AVR is because it is watching the heart exactly from the opposite side. The current is going always away from it. So that's why the deflections will be there, but they will be in the reverse direction. And that's why this is AVR. For the ECG paper, this is the speed which moves at the speed of 25 millimeter per second. And when we calibrate, this is about 1 millivolt. 1,000 millivolt makes 1 volt. So this is just, we are talking about 1 millivolt, and its deflection would be exactly 2 big squares, right? 5 big squares, or the 5 big boxes. It takes 1 second to clear that. Right? So there will be 300 big boxes per minute, or the 1500 small boxes. This is what is called as the calibration. It is to be done whether digital or manual, but it has to be done before we start any of the ECG recording. So easy part, heart rate 300 upon number of big boxes between any 2 consecutive. Yes, there was one email. Not only RR, that was because RR was very prominent. Yes, surely you can take P wave Right? But usually the P wave is smaller, but doesn't matter if it is seen clearly. We can add number of big boxes between any two consecutive waves. Right? The question was valid. It is RR was just for the reference. And usually what happens, the QRS complex is seen more clearly because big muscle, so the deflection will be high. So that's why they are selected. But otherwise, yes, you can take any other way. To be accurate, right, this is for accuracy. This is for accuracy. And you must have seen that when you were calculating through the big boxes, it was coming 100. And then when you calculated the smaller boxes, it was coming to 714. Right? That sort of answer was coming up. We will just see this. But so I think after this, it was just the calculation. Right? So let it go. Let's start with our today's work. So here, a standard ECG. Right? This one is P wave. Right? This one is Q. This is R. This is S. This one is T, and that's U. So starting with P, as you already know, that this is for the atrial depolarization. Atrial depolarization. QRS complex, that is for ventricular. Let's see that. This is for ventricular depolarization. After that, this is ventricular repolarization. When we say depolarization, that is current increases. Right? And then finally U, that is for the repolarization of Purkinje fibers. So that is a repolarization of Purkinje fibers. It can be present or it might be absent. If it is absent, nothing to worry. It is completely normal. Okay. So here the P wave starts. Right? All the way from P to Q. Right? All the way from P to Q. This is the phase. Right? This is the P wave plus the delay. This is the delay. It means the current is actually, at this point of time, during that delay, it is waiting at the EV node. Later on, we'll see even how can it really generate that delay. Right? Which type of channels they will be working, which are the slow channels, so that it can generate that delay. So that is the delay. Right? So this delay is what? This delay will be the filling phase. What would be filling at this point? Ventricles will be filling. Right? So it is the ventricular filling phase. And it makes sense also because ventricles will fill and then the current will go to ventricles and they will contract and things will be pushed out. Right? Blood will be pushed out. Then from P all the way to the beginning of Q wave, now this is what you need to remember. Correct? The beginning of P wave and the beginning of this Q complex, Q, this is called as P, not the PQ interval, it is called as PR interval. Whenever things are like this, that is the point where one can easily fall in trap. Though this should be the PR, no, but it is the beginning of QRS complex. Now QRS complex, that is considered as 1. Right? It is called as the QRS complex. In a minute, just in 1 or 2 minutes, we'll be discussing about why this Q is negative. If that question has arisen in your mind, because when the heart is here, the current is moving in this direction, current is not at all going back, so then how can there be a negative deflection? Am I clear? What I'm asking is that if the electrode is over here, let's say this is lead number 2, so lead number 2, then our SA node, EV node, bundle of haze, right? Bundle of haze, Purkinje fibers. Okay, when the Purkinje fiber comes to that is over here. Right? That is over here. So that is at a later stage. Right in the beginning, the current is not taking a U-turn and then go once again further. Because then and then this portion can be negative. And invariably it is coming negative. There is a very wonderful reason behind it. So we'll just see that. Before that, we just finish this. So this is the PR interval. That is the PR interval. So PR interval, we will remember it like it is the P wave plus the delay, right? Plus the delay. Q, R is rising, S is sinking, it is going down. So then when the S gets completed, right, S gets completed and T wave starts. This phase, this is very sharafat, it is called as ST segment. ST segment, simple as that. So no big deal. Right? Then once again, this is the Q wave, when the Q wave is there, right? And this is the end of T. So that is called as QT interval. This one. So QT interval. Again, this is also clear, right? Because this is the beginning of Q wave, beginning of Q wave, right? Over here, Q wave, and the ending of T wave. So that is fine. But over here, what it is taken is, this is Q now. So here also like this. Here also it is like this. The beginning of this QRS complex, though this is the Q wave. So here also, remember this part. Remember this part. So remember this part. It is this point. This point is very important. So now it is fine. PR interval plus QT interval, that will make the whole ECG. Correct? PR plus QT, that will make the whole cycle. ST segment is part of the QT interval. So far, all good. On to the some important aspects. One, which we have already talked about, that the QT interval, right? This is the QT interval. This one, QT interval. That QT interval should not be more than half of the R interval. So this is what we'll write. That QT interval should not be more than half of the R interval. R big waves. Then there can be some QRS variations. Right? This is called as QRS variation. Now, out of all these waves, Q wave, R wave, S wave, the least important is Q wave. Right? Sometimes you might get the absence of Q wave. So here, the ECG would really look like this. There is no Q wave, up, down, and continue. It can occur like this. So when we have just like this, that is no Q wave, there is R, there is S, and then it goes like this. So this is R, this is S, and this there is no Q. So this pattern would be called as just the RS pattern. Then it can occur like this also. If this occurs, if this R is rising, S is sinking, this is again called as R. So it is RSR pattern. And that is also a normal one. Sometimes if the wave is very small, right? Or sometimes if it is very big, so capital or small. Let's say if the Q wave is like this is Q, this is R, and then it goes like this. So this is Q, this is R. So in that case, we'll be calling it as QR because they both are big. But if it is going like this, just like this, and then, so here the Q is very small, this R is normal, so we'll be calling it QR pattern, like QR. So smaller alphabet, that means it is. Regarding the timers, Now you'll be developing one more habit, and that is you have to measure now the PR interval. So when we say PR interval, that means all we need to see the beginning of P wave and the beginning of QRS complex, that is the PR interval. So let's take any of the ECG. That's right, we can take this. Any lead is fine. Our intention is to find out the PR interval. So let's take this. Let's take this. So here it is the P wave and the beginning of Q, right, QRS in this only also, right? See, you will notice that Q is less, but this is the beginning of Q. So how much, what distance it is? Roughly one big square. Roughly one big square. You can look at it. Okay, in this, as such it is seen clearly. So here, what is the PR interval? PR interval. This is a T wave. Here it is, right? This is P and this is the QRS complex, the beginning. So the distance would be this to this. Almost one big box, right? Over here, see this. This is the beginning of P wave and this is Q. So how much distance it is? In timing, 1 square. That's right. That's right, 1 square. But over here it is more, right? Here it is more. So this big square is over here and the P wave is starting from here. Now do you know the reason in this? That paper was moving at fast pace. But my question is this. What would be the timing? How many milliseconds? How many milliseconds? So we calculated that at what pace paper moves. Paper moves at the speed of 25 millimeter per second. 25 millimeter means if 5 such boxes they move, right? 5 big boxes they move per second, correct? So one big box when it is moving per second, so that means so 5 big boxes. So one box will take how much time? 1000 divided by 5, that is 200 milliseconds. Correct. So when it is 200 milliseconds, that means this much is 200 milliseconds. That means one small box would be how much? 40 milliseconds. Are you with me? There was 5 big boxes that was taking 1 second. 1 second is equal to 1000 milliseconds. So one big box, that would be 1000 divided by 5. So it is 200. Now in one big box, there are 5 small boxes. Small boxes, correct? So 200 again divided by 5. That would be how much? 40 milliseconds. This means every small box would be moving at 40 milliseconds. Now over here, if you really want to calculate this is one big box, right? So one big box, that is 200 milliseconds. And then there are 2 small boxes. So each is 40, 40, so 80. So the total distance in this case is 280 milliseconds. Am I clear in this? So I give you one to calculate by yourself. Any doubt in this? Yes. So all good. Let's consider that everything is fine. Calculate the PR. That's right. We can. In this. I'll explain again. Okay, 1, 2, 3, 4, 5. Okay. I'll explain again. So let's print on this blank page. The speed at which the paper was moving was 25 millimeter per second. 25 millimeter per second. That's the speed at which the whole thing is moving. Now, 25 millimeter is how much? It is 2.5 centimeters. Right? Now, we have got the boxes. So each box that is of 5 millimeter. Correct? So that means when we say 25 millimeter, so can we say that this is a big box? Right? So 5 big boxes are moving per second. So far clear? Right? So this means 5 big boxes per 1000 millisecond, because 1 second is 1000 millisecond. Right? So how much time would it take for one big box? That is relatively simple. So one big box is equal to 1000 upon 5. That comes to 200 millisecond. Till this point it is fine. Fatafat, yes, no. Okay. So this is 200. Now in one big box, there are 5 small boxes. Correct. So if you want to find out that what is the distance, how much time will it take to cover the distance of one small box? So again, 200 divided by 5, that comes to 40 millisecond. This is the time for one small box. So far clear? This much? Right. Okay. Now, in the example which we saw over here, right? So this is the beginning of P wave, right? So this is the P wave, and then the QRS complex is starting. So we have to measure the distance from where the P wave is starting and from where the QRS complex is starting. So that distance is what we have to take. So when we take this is one big square. From here to here, there is one big square. Right? And plus it is also taking 2 small squares. So that is total is there are 7 small squares. Right? Now each small square was how much? 40 millisecond. So multiply it by 40, and that gives you the value 280 milliseconds. Now clear? Okay. Good. So this is the PR interval, and PR interval should not be more than 200 milliseconds. Rule of thumb. That means one big box. See, calculations, they are not that complicated. Because PR interval, the moment you see it, is it one box or more? If it is more, then now that is delay. There is something wrong. Less than one box, fine. Move on to the next one. Right? Easy. Okay. I'm giving you PR interval. In this, fatafat. More than one box or less than one box? Take this. This is another one. Chalo, take this. This one. It is pretty typical. This one. See, this is the P Q R S T. Again, the next P. And it continues. By the way, what is the heart rate in this case? 200 milliseconds. Okay. Good morning, dosto. There is no response here. Else, what would happen if I'll just randomly, I'll just keep on speaking. I don't want that. $88 was heart rate. Must be. Heart rate 80. Chalo. So that is fine. Now tell me the PR interval. PR interval bolo. Heart rate to everyone has calculated correctly. 250 for heart rate. My friend, 250 is the heart rate. For heart rate, what we have to do is 2 consecutive waves. So यहाँ पे S, take this S wave, right? Just 1, 2, 3 big boxes, and this is like 3.5 big boxes. 300 divided by 3.5, right? So half value will be shifting. 3 is 100 and 0.5, so that would be roughly around 80. So 88 is the correct answer. Perfect. Or if you want to be very accurate, so then you go for the 1500 divided by this 5 plus 5 plus 5, 15, 16, 17, 18, 1500 divided by 18. Now you have started with PR interval. Yes, PR interval, yes, Atharu, you are right. Realme, you are right. Mazama. That minor variation is permissible, right? The important thing is what? Important thing is that PR interval should not be more than 1 box, and over here instantly you find that yes, it is definitely more than 1 box, because it is starting from here and this is starting from here. So definitely this is one big box. So as such we can see that it is within. So this is not normal. I mean, we are about 54. There are just 2 or 3, 4, 5 people are replying. 5 or 6 people. No, yaar. Bolo. Chalo. I give you one slightly tricky, but use your logic and don't get confused. Watch this. Sorry. Watch this much area. See, this is area, right? And now tell me the PR. Okay, I'll repeat for the heart rate, right? Acha, for chalo, heart rate. Heart rate is, see, this is one wave, this is second wave. Right? You can take any of the 2 consecutive waves. So what's the distance? There is one big square, there is second big square, and over here there are 2 small boxes. So this is 5, this is 5, that is 2. So 5 plus 5, 10, 10 plus 2, 12. 1500 divided by 12. So that would be 1200, and rest we have to just calculate somewhere around about 125, right? So if you divide 1500 divided by 12, so that will give you 125, right? So that would be the answer. So this is how it is calculated. Main to this is, so now the PR interval. PR interval. In PR interval, now the answers are coming up for PR interval. See, this is AVR. So in AVR, everything is ulta, correct? And that's where the P wave is starting. And over here, this is the Q wave, because right, this is reverse. So QRS, Q wave will be reverse. So here it is almost one big box, right? Almost one big box. See, from here to almost here. So yes, you can say that 0.16 second, that is also correct, or 160. So we have got 4 small boxes. 4 small boxes is 4 into 40. That is about 160 milliseconds. And yes, Mohammed, what you said is 0.16 second. Even that is also correct. If someone has said 200, then also it is correct, right? The idea is just to see that how it really falls. As such, you take this and you take this. Yeah, it is almost same, right? Great. So now your concept for PR interval is clean. The next one is the USMLE question. So this PR interval should not be more than 200. The second, and that was the QRS. Right? The QRS should not be more than 120 milliseconds. So 120 milliseconds is 3 small boxes. 3 small boxes, right? While this was one big box. So it makes sense. I'll just add one page over here. This entire one page I am keeping it for this equation, which is sometimes asked. Not very complicated, but you need to know. Right, so we said that QRS should not be, say, more than 120 milliseconds. Three small boxes. The next one is QT interval. Right? QT interval is very important. So this QT interval, so calculate the QT interval in this. In this, calculate the QT interval. You know from where the Q starts, from where the, so QT interval is what distance? I'll just remove this. QT interval. How much is the QT interval? The beginning of QRS complex, the end of T wave. Beginning of QRS complex, make it easy. Beginning of QRS complex and the end of T wave. Yes. अथवा calculate again. See here. Yes. All of you are right. Roughly 280. Correct. So from here, these are the two small boxes, and this ends at this big box. So yes, the distance is 7 small boxes. 7 small box, 1 big box and 2 Kushi. You are right. Right, Deepinta, you say 280 millisecond. That is right. We'll make 240. Chalega. That is 1 square here or there. Doesn't make Karthik. You are right. Mojana, Zoom. Durgesh, you said 7 small boxes. Correct. All of you are correct. Yes. So that now we know how to find out the QT interval. So QT interval, when it is one small box is 40. Correct, Kushi? So it becomes 7 into 40. That comes to 280 milliseconds. Okay. So we learned that. But tell me one thing. These rules, so they are fine. But what if the heart is beating at a very high pace now? Now how will you know? Because if the heart is beating at a faster pace, it means everything will be coming faster. So then QT interval won't it decrease? Getting my logic? What I'm trying to tell is that if the heart rate is faster, if the heart is beating, then this will be decreased. So this is where we'll be learning what's used clinically. Even if you don't know the formula, chalega, just the name you should really know. So this QT interval we talked about, but this QT interval, as the heart rate increases, it becomes smaller. When we said that it should not be the QT interval, it should not be more than 440 milliseconds. We just calculated it was 280, so it was pretty good. But it should not be more than 440. But with the increase in heart rate, or this QT interval varies, and that's why it is called as the QTC, corrected QT interval. Corrected QT interval. We'll not be going to much depth of it, but just knowing this much would be more than enough. And later on, when we'll be into final MBBS or when we'll be learning medicine, we'll actually calculate. But you can try to calculate by yourself also, not very complicated. This thing is called as the Bazzett's formula. There are in fact 3 formulas, 3 different formulas, but that comes into the post-graduation of cardiology. Right? But at least we need to know, because this was asked once in university, the Bazzett's formula. So Bazzett's formula is for corrected QT interval. Corrected QT interval. So it should not be more than 11 small boxes. Perfect. You're right. It should not be more than 11 small boxes. Absolutely. Right. So Bazzett's formula. What Bazzett's formula tells that corrected QT interval is equal to the normal, the QT interval which you measure, and the square root of R interval. This is the formula. Right? Now you can just go through the ECGs and you can just calculate this. The importance of QT, when it decreases, when it increases. We just discussed briefly about it. Right? When to use it. This is to be used in very typical patient. Right? One, patients with syncope, that is those patients who are fainting, right? Fainting, or still more important, and that is those patients who are on QT prolonging drugs. Now, there are very specific drugs, so in which this QT level it gets long. And in this case, say in any of these variation, when there is decreased calcium, so it is called as the hypocalcemia. When there is decreased potassium, so it is hypokalemia. When there is decreased magnesium, so it is called as hypomagnesia. In all these things, QT will be prolonged. Also, you'll find that it is prolonged when the metabolism goes slow. So in case of, say, hypothyroidism, so this QT will be prolonged. It gets prolonged even in case of, I'll write it here, hypothermia, when the body cools down very, especially those who are going on poles, right? North Pole, South Pole, extreme cold, right? So when the thermoregulatory system goes away, so in all these cases, it rises, QT level, it is prolonged. When it is taken that on QT prolonging drugs, any of the antipsychotic drugs, right? Antipsychotic, makes sense, no? Because patient is violent, so you are giving antipsychotic drug. So all the drugs like, say, droperidol or risperidol or all DON, right? Or say thiopyridine, all those drugs, then anti-arrhythmic drugs. See, think it like this. Don't worry about the names of the drugs, but think it that what they do. Antipsychotic, patient is violent. You want to subdue that patient. So yes, heart rate would be slowed down. Right? Anti-arrhythmia, heart rate is heart is going into flutter, right? So it can anytime it can collapse. So you can give sotalol or amiodarone. So you will be giving anti-arrhythmic drugs so that you suppress all those centers. So when the centers are suppressed, so you will start sending signals slowly, right? In some of the antibiotics, these are not all antibiotics, but especially this is classically seen in this fluoroquinolones. This fluoroquinolones, those medicines, they are one of the important chapters into the antibiotics. Then antipsychotics, antidepressants, all these things. Right? Diazepam, something which people usually take for that sleep. Right? So all those things, they will be leading to this QT prolonging. So in such cases, when the heart rate is going so slow, right? So the value might cross 440, and then you'll be in tension. At that point, if you use Bazet's formula, you'll find that the value decreases. It comes in under 440, right? And that is the corrected QT interval. What we discussed, right, on this much page, this is like almost 4 or 5 questions of USMLE. Now, this gives you the idea that what level they are expecting, right? Because you are not giving, say, USMLE right in the first year. You are giving the USMLE after completion of your second year. Right? So by the second year, when it comes to pathology, when we'll be learning cardiology to tremendous depth along with the pathology, that is when we'll be merging the medicine part also into it. Right? So at that point, yes, we'll be calculating Bazet's formula in depth. But right now, just knowing this much, if you are enthusiastic, right, and there's nothing wrong in it, you can calculate. Right now, you know how to calculate the QT interval. Right, so you calculate the QT interval. You know how to calculate the RR interval. So you calculate the RR interval, take a square root of it and divide, right? And you will get the corrected QT interval. And it is called as the QTC. Right? Just remember, it is called as the QTC, corrected QT interval. Okay. So here you have already calculated the heart rate. Heart rate was 75 per minute. Right? Just calculating small boxes or large boxes. This is when we said about the calibration. Right? The calibration, that is so important, because over here the paper speed was 50 mm per second. The paper was moving fast. That's why everything has been like expanded. This is where I told you to calculate the heart rate, and you did that. That is here. This is this. I remove everything. This is exceptionally long. See, this is lead 1. Over here, see this is the calibration. See this part. This part. Right? 2 boxes, right? 1 and 2. 2 boxes. So this is properly calibrated. Right? So this first square wave, right? This first square wave, what you get, and then the ECG starts. Right? So that first square one, this one, this one, this one, that is the calibration of voltage. And if this is less, let's say if this is less, so then all the ECGs, they'll be coming like this, very low voltage ECG. So there is nothing wrong with the patient, but because the calibration was done incorrectly, so that's why that sufficient voltage was not getting generated to plot it on the paper properly. So that is the calibration. And this is 1, this is lead 2, and this one is lead 3. So it is not written over here, but it is lead 3. When things are going like this, right, continuous long, that is what is called as the rhythm strip. It is called as the rhythm strip. This you will be taking when in some of the condition the heart is beating at an irregular level. Right? 2 beats are regular and then 1 is slowing down. 3 beats are regular and then 1 beat is slowing down. So if you take only for a smaller duration, you might miss the diagnosis. So in such case, the machine starts and then it is you keep on taking, right, for almost 15-20 beats. So in that case, if there is any variation, so you'll be knowing it. Variations, they are of 2 types, what is called as the regularly irregular or irregularly regular. Right? Not at all confusing. It is regularly irregular. Just understand the difference between both. Regularly irregular. So that means, let's say 1 beat is dropping. 1 beat is dropping. But it is dropping regularly. So at every 3 beat, 1 beat is dropping. So here it is, 1 beat, 2nd beat, 3rd beat, and 1 beat dropped. 1 beat, 2 beat, 3 beat, and 1 is getting dropped. This is what is called as the regularly irregular. Clear? Because this is means missing the beat is not normal. This I'm taking extreme case. Right? It can happen only with P wave. It can happen only with QRS complex. And these things, they will occur when there is problem with the pacemaker. Right? Because pacemaker is constantly not firing. After 3 fires, pacemaker is waiting, or it is going into some that phase, right? That refractory phase, which is not responding, and then once again it fires. So this is what is called as a regularly irregular. So this is one example, and so that is when you need to take that rhythm strip. So that when you take a long strip, you will find this is missed. Let's say this is missed. This is missed. So you know that yes, every 3rd bit is missing, right? And then your diagnosis moves accordingly. So that's what is called as the rhythm strip. The importance of rhythm strip to find out any of the irregularities, whether it is regularly irregular or irregularly regular. Irregularly regular. Irregularly regular means what? There is no pattern. 3 beats are normal, and then there is some abnormality. Then 5 beats are coming normal. Right? See, irregularly they are becoming regular. Suddenly there is one abnormality, so you just can't guess that how many beats will be normal. Say 3 bits are normal and then there is some error. 5 bits are normal and then some error. So, or for all such conditions, you need to go for rhythm strip. This is a normal sinus rhythm. This was, in fact, we saw that also. Right? A good calibration, lead 1, lead 2, lead 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, and V6, all good. Right? So this is a normal sinus rhythm. When we say normal sinus rhythm, it is SA node. Right? So happy SA node working, and that's what is called as the normal sinus rhythm. Okay. Now the next one. This time we'll be learning about the axis, right? The axis deviation, and we'll also calculate it. So here it is, the SA node, the AV node, right? Things are going like this, and then from here, right side and the left side, they are sending the signals to various chambers. So this is the right atrium, left atrium, right ventricle, left ventricle, and our axis. Our axis is this, which is going towards the apex of heart, that is the left ventricle. So that's our normal electric axis. Electric axis for the heart. And it is pointing towards whom? Pointing towards lead 2. Pointing towards lead 2. So that's perfect. This is lead 1, this is lead 2, this is lead 3, and the distance is 60 degrees. So we know this part. The next part is, now you have to see this. The same Cabera system. This one is 1 and it is plus. Correct. This is 2, this is 3. 60, 60, 60 degrees. Now can we really say that when we say that normal axis of the heart is towards 2. So it means this is the area in which the heart is there. Correct. This is the area. Now, to be precise, we'll call this much as normal. If the heart is within this much, we call it normal. Now, when the heart is enlarged, right? When the heart is enlarged, so this axis of depolarization, that is going to shift. So if it is shifting on this side, so we'll call it left axis deviation. We'll call it left axis deviation. We have not yet figured out, and we have not yet discussed that, yes, we know that this is the level, this is the point from where it would be, this is the electrical axis. But how will it shift and how will we see? Wait, right? So when it goes over here, so we call it left axis deviation. And when this axis will be going on this side, very rightly, we'll be calling it right axis deviation. Right? From this point onwards, right axis deviation and left axis deviation. That is what we talk about. Now, in which circumstances? We said that there was tug of war, and in tug of war, when the rope is moving towards one side, so either the persons, those who are on this side, they are super strong and they are pulling it. Correct. So here is our our normal, good, decent. Right? This axis is sitting normal. Why should it really be pulled on to this opposite side? The reason, who was there? The chamber which is present over here is left ventricle. When the left ventricle is hypertrophied, that means there will be more muscles. When there are more muscles, so that means there will be more current. When there is more current, so then axis will be shifted towards that side. Because over here, this area, it has got not that much current to pull it back. Because what you are watching is the axis which is present over here, it is the balance between right side and left side, and that's why it is exactly into that direction. But when the left ventricle hypertrophy occurs, so there would be more muscle. So this is LVH, more muscles. So axis is pulled. So this is 1. This is 1. No, but we said that there is one more reason. What if opposite person is weak? We are to normal, but that opposite person has become weak. So there will be less current. So they won't be able to generate that much pull of us. So even if with our normal strength, still the rope is coming towards us. And that is, who is pulling on the opposite side? Right ventricle. Right? So right ventricle musculature is pulling, left ventricle is pulling, left is more powerful. So that's why axis is slightly tilted towards the left side. But now right ventricle has become weak. If the right ventricle has become weak, so then even with normal strength, it will pull up, and in that occurs in case of when there is right ventricle myocardial infarction, heart attack. Right ventricle, right coronary artery, main coronary artery, there is blockage in there. And that has led to myocardial infarction, typically affecting the right ventricle. So when the right ventricle is affected, that means muscles of right ventricle has died. If they have died, so there is nothing, no current will be passing through it. So amount of current which will be passing through right ventricle, now it is less than the normal. Left side will pull the axis. So we will be getting left axis deviation. Right. So this is right ventricular myocardial infarction. Correct? These two things. You might ask then how to differentiate between LVH and myocardial infarction. 1. History. Whenever there is left ventricular hypertrophy, history will be long-standing. Patient will be having high blood pressure. Right? Patient won't be coming in emergency. When it is myocardial infarction, patient will be coming in emergency. Right ventricle failure is going. Right ventricle failure, that means right ventricle that is going for the pulmonary circulation, will lead to edema, right? And pitting edema. That means when there is edema, when it is pressed, so there will be khadda. It is called as the pitting edema, right? There would be a pit, and then gradually, and where it occurs, classically occurs on the feet, right? On the foot, on the ankle, right? Feet will be swollen, ankle would be swollen. So that is when the right ventricle is going wrong. So typical history. Second, it is not only this much, because we'll be seeing the signs of myocardial infarction also. On ECG also we can see that, right? So we'll learn that. But is this concept clear? Because everything is dependent on this concept. So similarly, what if there is right axis deviation? Give me 2 reasons. Right axis deviation. What are the 2 reasons in which there would be right axis deviation? Give me 2 reasons. Very easy. Right? Everything is written on board. Participate. समझ नहीं कुछ, any doubt ask, but don't be silent here. Unnati, 2 reasons. एक नहीं. The current in left side won't be more. नहीं, ये नहीं समझ आया. What you are asking is, नहीं, देखो, listen. More muscle or strength on right ventricle. नहीं यार, ऐसा नहीं. two conditions. See, when there is left axis deviation, so either the more muscles, that is left ventricular hypertrophy, exactly. So here there would be right ventricular hypertrophy, right ventricular hypertrophy. So when there is right ventricular hypertrophy, that means there will be more current on the right side. So axis will be deviated towards the right side. Done. Second reason. I'm surprised only 3 or 4 answers. Correct. Shweta, left muscular, थोड़ा correct करो. Left myocardial is fine. With chamber. Those with chamber. Because if there is any problem in the left atrium, then nothing would happen to the axis. So it is left ventricular myocardial infarction. That's right. Right? So logical. So this is, I hope this part is clear, because only few people are answering. So I'm just taking it for granted that you have understood. So if this much is clear, now starts next 15 minutes. Now starts the most complex of all. It is not complex, but it is everything you have learned till now you have to implement it collectively. Right? So at some point, even if you find it confusing, immediately tell. Right? I'll try to make it as simple as possible, but please do respond. Which part? Here, when we are learning, it will automatically be the revision. Don't worry. Right? Let's focus on this. So over here, we start with lead number 1. Right? This is the lead number 1. Right? Lead number 1. So can we say that this is positive and this opposite side is negative? Right? This is positive and this one is negative. So for lead number 1, if I divide it into 2 parts, I divide it into this, right, 2 parts. So this area is positive and this area is negative. This half, I should use the word half. Right? So if this is one line, this is positive, this is negative, in between it is 0. So from here to here, this area, this is positive, and this area, this is negative. So here, this is positive and unshaded part is negative. Is that clear? Right. If I say it like this, great. Right. So let's make it like this. And we drew a line. This is plus, this is minus, this is lead number 1. So at central point, it would be 0. So we can say that this is plus, this is plus, this is minus, this is minus. With perspective of lead 1. Right? So this much is plus. Because obviously this line would be plus only. Right? So this is for 1. Next one. This time we are doing it for AVF. So for AVF, what would be the situation? If I really draw it like this, right? If I draw it like this, right? And we have got the AVF over here. AVF, you know that. So how will be plus and minus? AVF is this side is plus, This side is minus. So here it is 0. So this means this would be the line which will be dividing. So for AVF, this is plus, this is plus, this one is minus, this one is minus. And because this side was plus, this side was minus, and in between it is 0. So any number over here, it would be always plus. Any number over here will be always minus. So far clear? Now we superimpose both of them together, right? And that is what is giving us very vital clue. This we divide. We are taking only 2 leads. Lead number 1 and lead number AVF. What lead number 1 was telling, lead number 1 said that this is plus, correct? This is plus, this one is minus, this one is minus. What AVF is telling, change the color. What AVF is telling, that towards me, this is plus, this is plus. Opposite side, this is minus, this is minus. Have you understood how we came to this conclusion? This is only chart, this one, which tells everything. Okay, there are. If there is any doubt, let me know. But otherwise, I've got 4 yes. So I'm considering all good. So this is plus plus. When it is plus, right? When it is plus. So this is the area of the normal axis. Our normal axis is over here. Now we'll no doubt. All right, great. So we generalized everything. We draw like this, correct? This is 1 and this one is AVF. This is plus, this is plus. So this is normal. This one is 1, this one is plus, this one is minus, this is AVF, this is plus, this one is minus, right? AVF. When it goes over here, a right axis deviation, when it goes into that quadrant. In that quadrant, this is I, this one it becomes minus, right? So over 1, it becomes minus, and this AVF, that remains as plus. So that is the right axis deviation. This one would be the left axis deviation. So in this case, 1 and the AVF, 1 is again plus side. Right? So this is plus. AVF has gone into negative, so it is the minus side. So there is, and extremely rare, right? When the right heart has enlarged so much so that the axis it goes above, right? So this is minus, 1 is minus and AVF is minus. So this is what is called as the extreme right axis deviation. It is rare, very rare. This much is now clear. All you have to do now is just watch these 2 leads. Just watch these 2 leads and you'll be able to say in which direction it is. Right? See how it is, how simple it is. Heart rate we calculated. Okay? So I'll just make a space. Heart rate we calculated. Which 2 leads we were supposed to watch? We were supposed to watch lead 1 and the lead AVF. So here it is AVR, here AVF. This is lead 1, lead 2, lead 3. So this has been taken again. So this is AVF. What you have to watch? You have to watch for isoelectricity. Lead 1 is always negative. Where is There is lead 1 is never negative. Which one? Where it is, lead 1 is negative. AVR, I think you are talking about, when it is showing the inverted pattern. Over here, what I'm trying to say is, when the lead 1, forget about the lead here, draw any line, right? This is 0. Any number over here, any number over here, this one will be plus, this one will be minus. So, any number you plot over here, any number, they will always be plus. Because they will be landing over here. Graph में अपने बताते थे. Right? So these numbers will always be plus. So that's why they say this is the plus side and this is the negative. So this is negative. So that's how it divides. What's that? Right? Chalo. The concept of isoelectricity. The concept of isoelectricity is when we are watching lead 1 and lead AVF. These are the two leads. When they both are plus. Right? So let's see this. Lead 1 is plus. Correct, it is plus. Lead AVF, it is plus or minus? Is lead AVF clearly plus or minus? Negative. Correct? दिखता ही है, clearly negative. It is going down, right? So this is negative. Done. You have finished the axis deviation. We just come back over here and we plot it over here. This one, lead 1 was positive and AVF was negative. So it is not here. AVF was negative. Oh, it means this is a clear case of left axis deviation. Here it is. This is a case of left axis deviation. In seconds, you know that. And now see, right? This is left axis deviation. How much time it takes? Seconds. You just see and you will say that what it is. Correct? Because when we say 1, the immediately picture becomes okay, when 1 is positive now. Right? When 1 is positive, that means it cannot become the right axis deviation. Because for right axis deviation, lead 1 has to be negative. So when 1 is positive, think it that way, right? Tune your brain in such a way, when 1 is positive, straight away go towards AVF and it has given you the clue that there is something. Because if there is no sign of heart attack, right, there is no sign of infarction, so pakka, we are dealing with left ventricular hypertrophy. Right? And when the 1 is negative, immediately watch that if this is negative, that is this AVF has to be positive, because both negative, that is extremely rare. Means in my life, I have not seen more than 15 such cases. I do have 3-4 with me, but not more than 50. Out of thousands of ECGs, not more than 50. So normally, my teacher used to say that if you think of rarest possibility, then you are rarely right? So don't even think about it. When the lead 1 is negative, immediately watch AVF. AVF is positive. In 99.9% cases, it will be positive. If it is positive, you are dealing with right axis deviation. So here LED is clear. Tell me in this. Here the ECG has been taken in slightly different way, right? So I'll just help you. This is 1, lead 2, lead 3, EVR, EVL, and this lowest one is AVF. This is the calibration. And all those V1, V2, V3, V4, V5, V6, they are taken like this, right? This is combination of the diagnostic. So again, come back to that. This is what? Shabash. Good, Nirman, Donya, Deepika. Yes. Atharv. Zoom user. यार अपना नाम बदल पता ही नहीं चलता कौन है ये दुर्गेश. What's the problem? Why? For RAD, those lead 1 has to be negative. This is lead 1. कहाँ है negative? There is negative. This is normal, right? No confusion. No confusion. Durgesh, just watch this, right? This is positive, na? Big positive waves, clear? So this lead 1 is positive, right? And then AVF is also positive, right? So positive, positive, that means it is normal. Got it? Oh, shabash. Chalo, one more. Then I'll teach you one more interesting. 5 seconds. 5 seconds. Answer. 5 seconds. Axis deviation. Yes or no? Fatafat. Yeah, no axis deviation. This is normal. Right? AVF plus. This is 1 plus. First to khatam. Next one. This one. Here, yeah, it can be a bit confusing, right? Whether to take this or this. But one thing is very clear. Look at the voltage over here and look at the voltage over here, right? So this is not that much positive, you can say. Even if it is positive, it is just slightly, it is almost baseline. So if we have to put it into the quadrant, we'll put it that this is plus plus. But when this is to be put for the AVF will go slightly towards this. So yes, the chances of left axis deviation are more. And so many of you have answered it correctly. Faiz, Hardik, Shweta, Omkar, right? Good one. Shabash. One more. What has happened to others, sir? How many of you? 40. This one. I'll explain again, but I'll explain. But let's first everyone decipher this. This is important, right? Try to answer everyone. Faiz, very good. Deepmita, you are telling or asking? Natit, see again. Omkar, see again. यार क्या कर रहे हो? Watch again. My, see this? See, watch this. Is more positive or is more negative? हाँ, इसका बोलो. ठीक है, ओमकार. This is negative, ना? Exactly, exactly. So when one is negative, more negative, right? Exactly, more negative. Think it this way: that if there is deviation, means if this is lead one was where? Lead one was apna here, right? So if this one big, this is the right sided. If that is hypertrophy, the current is going there. So current is going away from us. So that's why we are getting more negative. When we are getting more negative, this is one. Immediately AVF. AVF positive. Bas, to pakka. Baat khatam. This is the right axis deviation. This is a case of, clearly, this is a case of right ventricular hypertrophy. That's right. That's right. Good. But somehow today very few people are answering. Means I mean Unnati, Mohammed, Durgesh, Kritika, Zoom user, Idonia, Hardik. Bas, I'm getting your only answers from this. Seriously, all of you answer. Chalo. Now, how wonderful would it be if you can, just by looking at the ECG, you can say not only the deviation, you can even say degree of deviation. That is how much heart has deviated. More, less, situation is good, situation is bad. You just see the ECG and you say, don't worry. And in the second case, both the cases, right, they are right axis deviation. But in one case, you said immediately admit and start the Lasix. And in second case, you are telling me, don't worry. Right? Just go home, take good rest. Right? No worries. Just from the ECG. Now we'll learn that. This is when you are going into the depth. Now, at MBBS level, rarely anyone would ask you. But because still, even after 1.5 hours, because even 40 to 40, you are here. So I feel like let me teach you this part also. But answer dena is part. Right? So here it is. The normal is plus. Right? They were isolated. We are going back to Kabera system. Fatafat answer. Which lead is this? This. Which lead is this? AVR. Here it is. Right? That's right. That's right. It is AVR. Right? Opposite side. And this one is lead 2. AVR negative. Correct. Right? So, but on ECG paper, we don't have anything like negative or positive. AVR is AVR. So, how do we get it? Think. How do we get it? We get the reverse reflections in AVR. Getting it? Right? Shweta, what you wrote is perfectly right. AVR negative. This is AVR negative. But apne paas there is only one AVR. So, but in that one AVR, if we are watching from this side, that means we'll be getting the reverse diffraction, right? Because it is the negative part of it. Okay, chalo. So, first I give you a small trick so that you never make an error. AVR, AVL, AVF. Out of this, LEFT, RIG, HT. More alphabets. More alphabets. So this would be related to 3. AVL, less alphabets. So this will be related to 2. And AVF, F for first. So that would be related to lead 1. What I am trying to tell you, I'll explain. But this is, in a flash you want to remember, then remember this. Whenever our answer will come AVF, so it will be lead 1 which is associated. The trick is in this, AVR and AVL. AVR means it will be linked with 3. AVL will be linked with 2. Now how? Let's see. See, this is AVR. Right? This is AVR. Which lead is 90 degree to the AVR? 90 degree to the AVR. Lead 3. That's right. This is 90 degree. So if there is some activity going on, right? If there is some activity, yahan se signal gaya, fir idhar gaya, so then 3 will watch, and how things will look like. Things will look like thak thak thak. Right? 3 will say yes, signal is coming, and then it is going. That's how 3 will see it. Correct? Because it is at 90 degree. So it is at 90 degree. Second, we do this. AVF. Who is at 90 degree? 190 degree. Right? So that also is fine. And lastly, AVL. Who is at 90 degree? Here it is. 2 is at 90 degree. So we have understood one part, that if we remember this, so this means these are at 90 degree orientation with respect to this. Correct? So I'm taking the first example. So plus, this is lead 1 and this is lead AVF. You have seen plus. So now there will be 2 possibilities now. The axis is either at 60 degree or axis is at 30 degree. So 30 degree or 60 degree. They both are normal. But because first we are learning the normal one, that's why we are taking this example. This is AVF. Right? So either the axis is at 30 degree or 60 degree. It looks so impressive when you say that, okay, this axis, this is a normal axis of heart with 60 degrees or it at 30 degree. Its importance, yes, it would come first, but first learn that. This 30 degree, which axis is over here? At 30 degree, which axis is over? At 60 degree, which axis is over here? Which lead? At this point, which lead? Lead 2. That's right. Lead 2. Yahan pe kaun si lead? At 30 degree, which lead? AVR. Exactly. AVR. Right? Plus minus, don't worry. But full lead is AVR. Correct? Okay. So when that is the case, what we have to watch is that over here, this is lead 2. So which lead is 90 degree of lead 2? No, 3 lead. That's right. Over here, see this one, lead 2. 90 degree of it is AVL. And which lead is 90 degree of AVR? Lead 3. So we'll see these 2 leads. What do we expect in this? will see that someone who is exactly at 90 degree now, he'll watch upward and downward refraction same. So they will be isoelectric, right? So we have to just find out that out of these two, who is isoelectric? Isoelectric means jitna upward deflection, exactly utna hi downward deflection. That should really occur. So chalo, let's see this. Let's see this. Acha, nahi, this is left axis deviation. The normal one. This is the normal one. Here it is. You have efficiently seen that 1 and AVF, they are plus, plus. Great. So this means this is what? This is normal. But normal to 30 degree or 60 degree. All you have to watch is, you have to watch these two leads. These two leads, this is AVR and this one is lead 2. Who is 90 degree to AVR? AVR 90 degree is lead 3. Let's watch lead 3. Lead 3. It is lead 3 is this. Right? Lead 3 is this. And which is other one? Lead 2. Right? Lead 2's 90 degree is AVL. AVR, AVL. So here it is the AVL. So we have got the lead 3, right, and the AVL. Out of these two, which one is jitna upward utna downward? That much variation is less. You can see that in AVL, negative is less and positive is very high. Right? While in this case, that deviation is very less. So lead 3 is considered as more subdued. Jitna upar utna niche, right? Nothing more. So this is the lead 3. Right? Now the lead 3 was, we are coming back to this, lead 3. So lead 3 is isoelectric. Lead 3 is isoelectric, so it is 90 degree to AVR, that means 30 degree. This means that particular heart was at 30 degrees variation. So it was at pointing towards the 30 degree. Normal axis, normal cardiac axis at 30 degree. I'll repeat that. Right? I'll repeat. This might be a bit confusing, but once understood, it is just. Let's do it again. This much is clear. I'm good. Right? This much is clear. This much normal. Okay. So when it is normal, both are plus plus. That means we are dealing with 30 or 60. You know? We are dealing either with 30 degree. We are dealing with either 60 degree. We won't be going anything like 12, 15, 25, 35. No. Right? Typically 30 degree or 60 degree. So this is what we have to find out. Achha. Visualize if the cardiac axis is this, right? So that means the current is going towards this. So for lead, which lead will be over here? Lead 2, right? Lead 2 will be jumping big spikes, right? Because current is coming. So lead 2 will be very happy, because cardiac axis is this. Lead 2 is watching large amount of current. Yes. Khush ho ke oh, bade spikes. But then someone who will be watching it from the 90 degree, how he will watch? Bada current aaya and bada current gaya. So this is up and this is down. So upward deflection and the downward deflection will be same. This is the concept. Is this clear? We have to really watch the 90 degree axis. And in order to understand the 90 degree axis, we created this cheat code. Right? Yaad, ek second mein yaad rahe. So when we say that even if you close your eyes, lead 2 means AVL, left. AVL, just watch, is AVL, right? Over here. with this, for example, we take this. So is the AVL, right? AVL like this, up and down, same? No, it is more towards the upside. No, this is not the case. So out of this, right, this is not. For AVR, who will be watching AVR? Right, AVR, right? So it is lead number 3, right? Lead number 3 will be watching it at the 90 degree. 3 it looks more reasonable, right? No jada upar niche jada nahi, within the range, right? So that's why this is more towards the 30 degree. Let's watch one better. Yeah, this is much better. Okay. Tell me this. Fatafat. It is so evident. You can't make mistake. In previous one, it was 30 degree, right? See, how do we approach it? Simple. 1 and AVF. 1 and AVF. 1 is positive? Yes, 1 is positive. Chalo, positive. AVF is positive? Here it is AVF. AVF is positive. That means this is a normal axis, right? When it is a normal axis, that means we have to differentiate between 30 degree and the 60 degree. 30 degree pe which was sitting 30 degree, that AVR was sitting. At 60 degree, who was sitting? Lead number 2 was sitting. But who will be watching it from the 90 degree? Well, for AVR, it will be watching lead number 3. For this, it will be lead number AVL, right? Let's watch who has got less variation. Lead number 3. Lead number 3. This is already color. This is the big one, right? Okay, let's compare it with which one? AVL. AVL. Here it is. Minor variation. Superb. That is 60 degrees. That's right. So this is the normal axis with 60 degrees. Interesting. Right. 60 degrees. Now these are all conditions. Yes. Chalo, this one. Tell me. This one. It's a very nice one. Follow the same pattern, same sequence. This is what watch for. 1 and AVF. 1 positive, AVF positive, right? So then you have to go for lead number 3, right? Straight away you can say, and lead number AVL. Lead number 3 is this, and AVL is this. Now see, AVL is only positive. There is no negative. And this one is having negative and positive both, right? So we'll be picking up 3. So 3, you take that, so it is at 30 degrees. Correct. See, this is the judgment you take. Atharul Muhammad, Idunia. See this. Right? Here it is positive. Here it is positive. There is no negative deflection. While over here we see the negative deflection and positive deflection both. So that is more near to our this pattern. We have to search for this pattern. But who is more near? So axis will be there. Now in real time, what happens? Sometimes the axis is say 35 degree, 40 degree, 47 degree, right? Such deviations they also occur. And there is a method by which you can even go to that level, but it is not needed, because in that case you have to just take the log of both of them and then you have to calculate. But that is no. Even if you do this much, it's a big clap. Right? So far clear? You know, this happens. The number has drastically decreased to 34. Because from the exam perspective, yes, I totally agree. People won't ask you this much. Next. We'll have still more examples, right? Now we are taking another one. Say this is 1. This is ABF. Correct? This time it is plus minus. So if it is plus minus, so then which axis are we talking about? If it is plus minus, then we are talking about plus minus 3. Which axis deviation? The right or left? Durgesh. अरे मेरे दोस्त, plus right, plus minus. So LED, we are dealing with left axis deviation. So when it is left axis deviation, we are drawing it again. Right? There would be 2 axes. There will be 2 axes. One will be at minus 30, one will be at minus 60. Correct? Am I clear? Right. Because यहाँ पे this was 1, this was at 0. So this first one is at minus 30. So which lead is at minus 30? Which lead is at minus 30? Excellent. AVL. That's right. AVL. Which lead is at minus 60? Which lead is at minus 60? That's right. Right? Because over here it would be 2, or यहाँ पे it would be 3. So this would be lead 3. Right? We are picking up fast now. So over here, we have to watch 2 leads. Right? One AVL and second one is the lead 3. If it is AVL, so then it would be minus 30 degrees. And if it is towards lead 3, then it is minus 60 degrees. Okay. But we can't watch, because if it is there, we have to watch the leads which are 90 degrees to them. So which lead would be 90 degree to AVL? Apna cheat code. That's right. Lead 2. And which lead would be 90 degree to lead 3? Apna cheat code. That's right. AVR. Done. Done. Now, let's go. Let's see this. So first we have to figure out that we need a left axis deviation. I think previous one. Yes, there it is. So lead 1 and lead AVF, right? Lead 1 is plus and this AVF 100% minus. So this is definitely left axis deviation. If it is left axis deviation, we have to find out which degree. And for that, lead 3 is minus 60, right? Lead 3, so it is minus 60. And lead AVL, right, is minus 30. But we have to watch what? 90 degrees. So here we'll be watching AVR and here we'll be watching lead number 2, correct? So lead number 2. Lead number 2, which one is isoelectric? Which one is isoelectric? Jitna upar utna niche. Superb. Right? Definitely this. Definitely this. Right? Because in AVR there is so much of variation. So very typical. Wonderful. This is definitely we are dealing with minus 30. So this is done, right? Now we take the last part. So this is AVR, LED we have done. You'll be able to understand this thing within no time. So here, when there is right axis deviation, so one would be negative, correct? On the opposite side, the AVR. So we are talking about this part. This was plus plus, but now this is minus and this area is plus, minus plus. So when it is minus plus, that means there are two axes over here. What would be the degrees over here and here? Degrees. What would be the degrees? They will be, correct. 120 and 150. That's right. 120 and 150. Because this one would be the 180. Yahan pe it was 90. Next is what you have to answer is, and you must have guessed, which leads? Is at 120, which lead is there? Correct. Correct. Lead 3. And at 150, which lead is there? Very good. Right. AVL. Right. So we have got AVL over here. So this is done. So now we have got 2, 120 and 150. And leads are 3 and AVL. So finally, which lead will watch? That's right. 2 and AVR, and whosoever is isoelectric accordingly the degrees. Done. Finished. So that's how we really see all the degrees. I'll be giving you more examples for all these deviation. Plus, we'll be learning now in the next session. We'll be learning about all the diseases. So there'll be one more session, and we'll be through with the ECG. This part was a bit tricky. We took time in order to understand this so that the concept becomes crystal clear. So what you now do is, this weekend, do revise it. I'll just upload this file in a minute. Do revise it properly, understand thoroughly, so that next time when we'll be discussing the disease, it will go like a flash, right? You just see that and you'll be able to understand. Okay, so it was right at least 30 people. So thanks a lot and take care. Wish you a very happy weekend. And now festivals are coming. So thanks a lot and we'll meet very, very soon. Take care. Bye-bye. I'll do that. I'll add, I'll put a plain file also. That's right. ECG without annotation so that you can practice. Definitely. This is the file, right? This is the file. So this file is comprising of last time's session and this time, both. Right? So this file I'll upload, so automatically you'll get both things. All right. So happy weekend to you too. Take care. See you soon.